Sounds good to me. Yeah. Yeah, hi everyone. Welcome to Cochrane South Africa's Systematic Review Methods webinar series. This series is run by Cochrane South Africa's Training Working Group, where we sort of deliver training and support in evidence-informed healthcare methods to researchers and students. And yeah, today I have the great pleasure of welcoming Dr. Charle Viljoen, who's going to be giving a presentation entitled Where Measuring Instruments Differ, Standardized Mean Differences as Effect Measures in Meta-analyses. Yeah, Dr. Viljoen is a cardiologist and specialist physician in the Division of Cardiology at Groote Schuur Hospital at UCT. He has a special interest in arrhythmias, device therapy, and heart failure, and is currently completing a fellowship in electrophysiology. In 2018, he was awarded the International Resident Leadership Award by the Royal College of Physicians and Surgeons of Canada and is a fellow of the European Society of Cardiology. So yeah, we are very excited and fortunate to have you here today, Charle. Just before I hand over to you, just a few admin issues. So if everyone wouldn't mind just keeping yourselves on mute during the presentation. Charle has indicated that he's happy for people to ask questions during, so please feel free to raise your hand or to type a question in the chat if you'd like to ask anything or give any input. We can really make this interactive. Yeah? But we'll also have time at the end if you want to ask questions then too. And then just finally, so that you know, we are recording the session so that we can put it up on the Cochrane South Africa website, so just so you are aware of that. So without further ado, Charles, thank you so much. I'm going to hand over to you.
Thank you, Sarah. Thank you very much for the kind introduction, and also the kind invitation to present here this afternoon. The disclaimer is that I'm a clinician. I'm a cardiologist and specialist physician, as Sarah said, but I enjoy research a lot, and I'd like to present you a paper which originates from my PhD research, which I conducted under the supervision of Vanessa Birch and Rob Scott Miller, who are the doyens of medical education and electrophysiology in South Africa, but also with Mark Engel, who was a great help with my systematic review meta-analysis, and from whom I've learned a great deal. And I'd like to share with you this systematic review meta-analysis in which we then use the standardized mean differences. So the point really of this afternoon is to go through this in detail, how we conducted the systematic review meta-analysis, and then how we then employed the standardized mean differences and why we chose this. And I'll show you some code how to employ this when you're conducting your own meta-analyses. So just I recognize the fact that perhaps on the call, not everyone might be a clinician or a medical teacher, but the ECG is probably the most used modality to diagnose cardiac disease. And knowledge thereof is crucial to diagnose cardiac disease, but we are more and more recognizing the fact that new graduates and also residents or medical registrars really across the world have failing ECG competencies, and many reasons for it. It's a very difficult subject matter, but also people are more and more relying on automated interpretations of the ECG, and for that reason, not themselves necessarily all that competent. And if you can't make a diagnosis, of course, you can't treat correctly. And for that reason, I conducted my PhD was really on how to teach ECGs. And there were multiple studies which we did in this, and really for the purposes of this talk, I'm going to focus on what was the first of the studies. The first chapter, which was a study, was a systematic review, which we really summarized the literature and meta-analysis, which actually puts everything nicely together. So really, how should we teach? And in this, what we first did is we published a protocol entitled "Is Computer-Assisted Instruction More Effective Than Other Educational Methods in Achieving ECG Competence Amongst Medical Students and Residents?" A protocol for a systematic review meta-analysis. And in the protocol, we in detail went through the methods employed according to the PRISMA P. And then finally, about a year and a half, 2 years later, the systematic review was then also published in BMJ Open. And this is the article that I'd like to use for this afternoon. So technologically enhanced methods of instruction are increasingly being implemented in training of healthcare professionals, and that's also true for ECGs. And when new things are implemented, whether it's a new medication, a new investigation, or for that matter, a new method of instruction, one needs to first review whether these are actually working, whether it's really effective before really employing on a grand scale. And previous studies have shown that students' knowledge of and skills in analysis of interpretation of ECGs improved with computer-assisted instruction, but unfortunately, the results were very variable. The way that the studies were conducted were also very variable, and it cannot really be concluded from previous literature whether computer-assisted instruction, or CAI, was better than traditional methods of teaching. We use this as the subject matter to ask the question, and the systematic review meta-analysis then followed from this. So, and as you know, I mean, this is nothing new to the audience. Systematic review then really not a narrative review, or really summarizing the data very nicely. And then what we could do is pool the data very nicely and conduct a meta-analysis for those studies that had adequate data. So the objectives of the systematic review were to firstly establish whether computer-assisted instruction achieved better acquisition retention of ECG competence amongst medical students and residents than other methods of ECG instruction, and we'll go through that shortly. And we also wanted to identify the types of learning material and other activities that were used in computer-assisted ECG instruction, and to establish which of these were really associated with better outcomes. And then finally, also, we wanted to see what educational approaches were used in computer-assisted ECG instruction, and to establish which of these were associated with better outcomes. So going back to how to conduct a systematic review, or actually any research study, the question then was asked, does CAI achieve better acquisition and retention of ECG competence amongst medical students and residents than other methods of ECG instruction? And then we employed the PICO method. So P standing for population, I for intervention, C for comparison, and O for outcome. And for that, we could say for the population was then medical students or residents. So that's postgraduate students. The intervention being computer-assisted instruction for ECG instruction. And the C, the comparator, would be any other method of ECG instruction, mostly traditional ways such as classroom teaching. And the outcome would be the measurement of ECG competence. And we use this PICO for both the search strategy and the eligibility criteria. And I'd like to show you the elaborate search strategy, which we designed with the help of a librarian here at UCT. And firstly, for the population, which we use then, of course, as I said before, medical students or residents enrolled for specialty training. We used both mesh terms on PubMed and free text. In the other search engines, we only use the free text, of course. And you can see here, really, we looked very hard for all the different kinds of terms to name then students or residents. For the intervention, computer-assisted instruction, there are also multiple terms for these, and we use the mesh terms computer-assisted instruction or computer simulation, educational technology, or internet. And then also free text, multiple different terms that are being used in the literature. We used all of these for the intervention, comparator being cardiology education or other methods of education, as you can see there, with the mesh terms which are allowed on PubMed. And then we used other terms which were used in the literature. So you can see large group teaching or lecture or simulator, small group teaching, workshop, self-instruction, self-study, all of these. And these were then all constructed together as the comparator. And then for the outcome, we used a combination. So it would be clinical competence and in that of electrocardiography. So the mesh term electrocardiography, which is then combined with competence or participation or performance. And all of these were then confirmed and combined. And as you can see here, finally, we used the 3, the 6, and 9, and 16 combined as our search strategy. Elaborate search strategy, which was employed, which found 500 odd articles, which we then reviewed. And then the eligibility criteria, we also used PICO, but we used PCOS actually here because we also included study. So here, population, medical students or residents, and we excluded students which were not medical students or healthcare professionals who are not medical doctors. For the intervention, we used online or offline computer-assisted instruction, but we excluded studies which did not use teaching modalities which are not primarily used for ECGs. I think that's the most important part here. And the comparator, we really try to be as inclusive as possible. So any comparative ECG teaching method, and it exclude the studies if there was no comparator because that would not fit the study. And for the outcomes, we specifically looked at the acquisition of ECG competence. And what that means is that you acquired new knowledge. You were taught something and you improved, perhaps. Retention, meaning retaining that knowledge after the teaching. Also measured Kirkpatrick outcomes, which is not important for this talk, but it's a way of measuring educational outcomes. And then the studies that we included were mostly randomized controlled trials or cohort studies. We obviously excluded case series and historical narrative survey-based or letters and audits and that kind of publication. So combining all of these, you can see that we identified 592 studies. We included another 32, which we went through the citation indices and hand searching. And after removing 65 duplicates, we were left with 559 titles and abstracts, which went through in duplicate. Full texts assessed for eligibility after we excluded not relevant to ECG teaching 437 articles, went through 122 articles, the full text thereof, excluded them for the reasons which are showed here at the bottom right. And then finally, which could be included in the systematic review for the qualitative synthesis, 13 studies, and only 8 of these had enough data which we could then include in the meta-analysis. And we'll go through that shortly. So 13 in the systematic review and 8 in the meta-analysis. So here's a summary of the studies, and it's important to actually understand what these are before we go through SMD shortly. But you can see that in the 13 studies which were included in systematic review, 12 of which were students and 2 had residents. So there was one study which combined students and residents. That's important. You can see that 9 studies were randomized control trials, 4 were prospective cohort studies. And you can see that also some of the studies used computers as instruction with face-to-face teaching, 4 of those, whereas 9 use CAI alone. So you can already start seeing there's a lot of variability in this. Also, the ways that the ECGs were taught, you can see that 3 had massed instruction. That means it's all only in one session. 9 studies had distributed instruction, so it means that there were multiple sessions during which the students were taught, and one study didn't even tell us how the instruction happened. You can also see that online and offline, 7 were online, 5 offline, 1 study didn't specify. And then from here at the bottom, you can see what was included in the computer instruction, and it's very variable. Some used text, images, some used, only 2 used chat rooms, 2 didn't actually specify what this CAI really was. Only 10 of the 13, and that's actually perhaps a little bit worrying, included a real patient 12-lead ECGs in their studies. And also what was taught was very variable. So I understand that the audience might not all be clinicians, but in ECGs, I mean, there's a set curriculum that we teach, and it's roughly what you see up there. And you can see that the studies, it was very variable also what was taught. shockingly, actually, is that only 6 of the 13 studies had a pre-test, so to know where they started off. The post-test was, of course, done in 13, otherwise they would not be included in the study, and only one study looked for retention of knowledge with a delayed post-test. And then you can also see the way of the method of teaching was very different. Some used multiple choice questions, some used short answer questions, and 3 didn't even tell us how the students were assessed. So the reason why I'm showing this is you can actually see that there's a lot of variability in the included studies, and that's very important in the topic that we will be discussing this afternoon. This is just a timeline over time. The oldest study actually dates back to 1965. Can you believe it? There were already computers back then used for ECG teaching. 2 studies in the 80s, and then there were these there was a hiatus after that again. And then in 2007, again, they started publishing, and actually more and more publications in the last decade. And actually, it's much, much more since 2017, but that was the cutoff for this systematic review and meta-analysis. Says the studies, of course, for bias, and you can see there was a lot of bias in the studies as well, the way that students were selected, how their performance was assessed, and also some attrition bias and reporting bias. Also important too, and this really depends on what the subject matter is, and I'm just showing it. It is a Cochrane lecture, but for medical education, what we can use is the Mirsky scale. So it's a medical education research study quality instrument. You can see that what we used here is to it's actually quite a nice tool. Actually, sometimes I struggle to find such a nice tool for clinical research. But you can see here the scores really scoring high if it's a randomized control trial, if it's at more than one center, if the response rate is more than 75. The validity evidence there was internal structure and all of that. So you can see from this slide how detailed the score is, and the mean score across the studies was 12.73 out of 18. And really similar for the students and the residents. So just to give you an overview of what the quality is of the studies that we included. Just to go in a little bit to what the studies included, you can see here, for instance, this first study by Barthélemy from France. They had some students from or residents rotating through emergency departments in France. And they gave the one group 4 months access to e-learning course, and the other group only had 2 lectures of 180 minutes each. Next study from China, they had the one group had a flipped classroom method, and the flipped classroom means that they had some computer-assisted instruction before coming to class, then had class, and then had some computer-assisted instruction again after class, whereas the other group just had lecture-based learning. And then another group from the USA where the students had an ECG teaching module, and the other group just had one face-to-face teaching session. Another group from the UK where the one group had e-learning module, which was a single once-off exposure, whereas the group which did not have computer-assisted instruction had near-peer teaching. So it meant that other students were teaching them. Also as a once-off 30-minute teaching. And it's actually surprising that you would think that only teach one session and that's enough for ECG teaching. But yet they come with very, very strong recommendations after these studies. And really one needs to look at this very, very critically when including. And so it continues. So you can actually see when you go through these different studies, lots of different methods applied, lots of different content, lots of different study designs and all of that. And that's important to understand when putting all of this together. So as a summary, in the computer-assisted instruction, there were 9 studies which used computer-assisted instruction alone, 4 which used blended learning, of which 1 was this flipped classroom, which has CAI before lecture, and then 3 which used CAI after the lecture. And then even in the face-to-face teaching, there was a lot of variability. Taught by a teacher or a lecturer and someone who's experienced in ECGs, 12 studies. 1 was the near-peer teaching, as I've mentioned before. And then large group teaching or big lectures, as we all know them, 9 seminars. So it's something which is organized outside of normal formal teaching, 2 studies and 1 tutorial, small group tutorial. So you can see there's a lot of variation amongst the different studies. So just to then take a step back, in randomized controlled trials, endpoint scores or change in scores, which represent the difference between endpoint and baseline, are key values. And in the design in this study, that was crucial because we want to know what happened before an intervention and then after intervention. And then you want to compare the outcome in the group that had the intervention or not. And this could be true for anything, whether it's an educational intervention, medical intervention, surgical intervention. This holds true for any study like that. And these values are then compared between the experimental and the control groups and to determine the mean difference for each outcome. So this is important to understand for the rest of the talk. So when mean difference values for a specific outcome were measured in the same unit, so say for instance you use blood pressure measurements, it's always millimeter mercury across different randomized control trials, they can be pooled in a meta-analysis. So, and this is just an example here. This pooling yields a summary estimate known as the mean difference. So you can use the mean difference when it's the same unit in which it was measured, and you can put these then together. And then depending on how large the studies are, then of course there's a weight attributed to it. So you can see here in this study by Singh 2009, in this meta-analysis here, it's just an example to show you it's 46.4% of this entire meta-analysis really relies on the results by Singh. And the smaller the study, of course, so a study here in 2003 by Yates would only contribute 2.7 in this weighted mean difference. So it means that, yeah, as I've mentioned before, it's a summary of it's the mean differences then all pooled, but the weights then attributed according to how many patients are then allocated to the study. So this is what is done with a weighted mean difference. However, and just to start with that is how can you do this? So I strongly urge that you download the Review Manager, which is from Cochrane. The one I have on my computer still is 5.4.1. And what I did here is I entered all the studies data into my Review Manager 5.4. And what you can see here is I labeled them all the studies here according to the author and the year that these were published. And then the subgroups here, CAI as the intervention group, lecture then being the conventional or the control cohort. And the details that you would need for these analyses then being, you would need the mean, and in this case, in our study, of course, it would be the mean result of the ECG test. So a percentage, so you can see here what the differences were. In, let's say this Iranian study right at the top, there was a difference, or no difference, 72 in the group who had computer-assisted instruction versus 71. But that study didn't include a standard deviation, so for that reason, it falls out of the analysis. If you take the second study by Barthélemy from France, you can see that for them, they had a mean result of 59.5 after the intervention with a standard deviation 12.25. 19 students in that group, and then versus lecture 51% with a standard deviation of 13.72. 20 students in that group, and you can see that overall in this study, it contributes 4.1% then to this overall meta-analysis, with the mean difference then being 8.5. So between 51 and 59.5. I mean, that's relatively easy statistics. And you can see there that it also gives us then a confidence interval after the mean difference. However, I'd like to draw your attention to a couple of things. This is when we use the mean difference with fixed effects, and I'll go through all of these things shortly. So it's relatively easy to do. You go to the data and analyses, you enter the data onto this table, which is here. It's quite interactive. You can click on the different blocks, enter the data from the studies, and it will calculate the weight and the mean difference for you. And then you can use the toggles at the top, as I'm going to show you now. So when you consider this, oh, and then sorry, also very important is that the inverse variance method is this statistical technique that is used here in the meta-analysis to combine the results in the multiple studies, giving more weight to the studies with less variance. So the the more participants are in the group, the less variance there will be. And this is the method that is used here with this with Review Manager in doing this analysis. So that's important to understand, because you will see here in the forest plot here on the right, you will see mean difference, and then you'll see that IV, which stands for the inverse variance, and you'll see it's fixed variance, and I'll explain that to you shortly what that means, and then with the confidence intervals. So the little green block gives us then the mean difference. If it's in the negative, it's obviously the lectures did better, because that actually the CAI did worse. Positive favors then, of course, computer system instruction. And then the confidence interval is the black line, which is indicated there. So if you looked at the results that I present, if I took these studies that were included in our systematic review, the 13 studies which are from the systematic review, which you see here, 8 of which had enough information to include in the meta-analysis, because they actually also gave us standard deviations. And these authors were contacted, for instance, Montassier and this top study, this one at the top, and I asked them for the standard deviation. Unfortunately, if I didn't get a response, we couldn't include these studies. So they will then fall out of the meta-analysis, of course. But if you enter all this data and you look at the mean difference between the studies, you might actually think, even weighted, that a computerized assisted instruction actually looks better than lectures. But then I start asking myself 2 questions. The one is a weighted mean difference of 6.4 actually significant? So what is significant? When does it become significant? What is enough? Is it enough to say that, you know, this group scored 6.4% more than the other? And that's the first problem that's there with mean difference. And the more important problem is using this method, is this method actually appropriate? And why I ask this is, I've put a lot of emphasis on the fact that how different these studies were, how different the study designs were, the content of the teaching, the interventions were different. And is a mean difference then really appropriate? Because it seems that the tests were different, or the way that the things were measured are all different. So if that's the case, so if the tests and what was taught and what was tested are all different, can you actually use the mean difference? So are you comparing apples with apples, or are you busy with a fruit salad, apples and pears? And that's really, really important here. So to correct for this, sometimes different studies use various rating instruments. And this could be, and it's not necessarily an ECG teaching, the tests were different. It could be that you'd like to assess the cognitive impairment of a patient, and there are different scales that are used, or measuring the anxiety of a patient, and there are different anxiety scales or ratings that one can use. So when studies like these are all pulled together, when different studies use various rating instruments to measure the same outcome, so cognitive impairment or anxiety, resulting in different units of measurement across the studies, this is when we then use the SMD, and I'll come to that now. So in such cases, the mean differences from the different RCTs cannot be pulled to directly. And what is done then is the SMD, so the standardized mean difference, is calculated by taking the mean difference and dividing it by the pooled standard deviation. And this then gives us you actually convert the studies into the same units so that you can actually pool them. And what's also nice about it is it's like the effect size or a Cohen's d. It gives you a value which you can interpret, and you can actually say what the clinical significance of the study is. And if the study then has an effect size or an SMD, which is 0.2, you know that it's small, or 0.5, it's medium, or if it's larger than 0.8, it's large. It's actually said that 1.2 is very large. So by doing this, SMDs can then be pooled in a meta-analysis because the unit is consistent across the studies. I think that's the important part here. So what you're doing is you're taking mean differences and you're giving it all the same unit, and then you can pull it from there. And that's the take-home message from this. And the nice thing, as I said, also is the effect size also tells you the clinical relevance of the results. It's almost like don't like to use the word p-value, but it's almost another value. So p-value telling us statistical significance, but then the Cohen's d giving us clinical relevance. Is it actually, does it make clinical sense? So taking the same results that I'm showing you here, so the 13 studies which I entered and the 8 actually really which are in this meta-analysis, if I then click on the button here at the top, which is the SMD button, so if you do a standardized mean difference here, you will see that the results look slightly different. So it's not, so let's just go back. It's not the standardized mean difference here of 6.4 anymore. Sorry, it's not the mean difference of 6.4 anymore. It gives us a standardized mean difference, which is like an effect size, which gives us a value of 0.45. And the unit then is like the Cohen's d. You need to understand what this value means. This value is not, there's a difference between the study of 0.45. It gives you an indication of how relevant the results are. And 0.45 is close to 0.5. So it's probably a moderate effect. And that's the first thing which is great about using the standardized mean difference here. But the next is at the moment, and the results I'm showing you here are still with fixed effects. And that's important to understand because fixed effects you would use if everything, the study populations looked the same, the study designs looked all exactly the same and so on. But we need to take in consideration, I'm going to put a lot of emphasis in the beginning of the talk of how different the studies were in terms of what they were teaching, how they were teaching, and all of that. So yes, it is true that the SMD of 0.45 shows a moderate effect size, 0.45, in favor of CAI. But is it appropriate to use the fixed effects as I'm showing you here? There was a significant variability amongst the interventions. And for that reason, let's just quickly have a look at this. So in a meta-analysis, the choice between random effects and fixed methods models influences how the SMDs are interpreted and pulled. So if we just compare the two, so the fixed effects model assumes that the true effect size is the same in all the studies. So the differences observed are just attributed to sampling error within the studies. So the pooled SMD then represents the common effect size that is assumed to be true for all included studies, and it's appropriate when studies are very similar in terms of participants, interventions, and outcomes. However, you need to click that the random effects button on this program if like in this study or in this meta-analysis where all the studies looked so vastly different. And the reason for that is the random effects model acknowledges that the true effect size may vary between the studies due to the differences in the study populations. I mean, I told you that some studies had residents and other had medical students. The interventions were different. Some included small group teaching, others had large group teaching just in the comparison group. Some compared CAI alone, but others combined it with some lecturing. So the interventions all look different. And for that reason, the correct thing to do here is not only to use the standardized difference, but also to acknowledge the fact that the studies were different. And therefore, the correct way of performing this analysis would be to do this according to a random effects model. So again, I'd like to show you the results. So at the moment, this forest plot is showing you the results according to this standardized mean difference with the fixed effects. And the moment we then toggle the random effects, which is you just click on the button there, it's quite easy on this review manager. You will see that all of a sudden the results are actually non-significant. So if I just go back, you can see here that the confidence interval did not cross the 0 line. However, when we acknowledge the fact that the studies looked so different with a random effects model, actually the computerized assisted instruction actually lost significance, and there was perhaps a tendency to be better, but actually it didn't reach statistical significance. And that's super important to understand. And it's the same set of data, it's just the way that you're looking at it. In this way, the correct way of correcting for all these differences actually you make the best sense of the data.
Charle,
So,
sorry,
yeah.
I'm very sorry to interrupt you. I just see there are some questions coming up in the chat. I wonder if this is a good moment to pause and just, should I read some of them, or would you prefer?
Yeah, I think we're almost done, and then perhaps we should tackle them all at once. Yeah,
Sounds
so the next from here is, I mean, this is just a summary of the results. You can see here that um, the overall computer-assisted instruction was actually not statistically more significant. There was no statistical significance that computer-assisted instruction was better than traditional methods of teaching. And here is the status code for this meta-analysis, which I show here. And for this, what we used is the meta instruction. And what you would use is then three variables. You would use the number in the cohort, the first cohort. You would use then the mean score for that same cohort and the standard deviation for that that same cohort for the test that you are using. And then after that, you would use the number of the cohort, the second cohort, so the control cohort, the mean score and the test, and then the standard deviation for that test, whatever the test or the measure is that you use. And you would then use the random effects, as I've just shown you. Our X line would be at 0, of course. And this is just the way that we labeled this, with the effect size being from -2 to 0 to 2. -2 being, it's the same way you can interpret it. It's just that it's negative as opposed to positive. And then, yeah, all the rest of the code, you can take a screenshot of this if you would like to apply this for your own work. And then it would give you something looking like this. And then finally, what we also did, and this is quite a cool also way that one can employ the review manager, is what we did is we looked at the different educational approaches or learning materials that were offered by computer system instruction. And I only included the studies which used these, and then I used the pooled effect sizes to see what happened. So for instance, here, if you looked at the studies which used blended learning, you would see here it included 3 studies, 422 participants, and you could see here that the pooled effect size is 0.8, so it's very large, or large, sorry. But if you use CAI alone, so not in blended, not in the blended learning fashion, you would see that it didn't reach statistical significance. So this is another way of looking at the data. Frequency instruction, for instance, you can see multiple exposures, 5 studies there as compared to single exposure. Access to computer assisted instruction multiple times or unrestricted, etc. If they use case scenarios, online chat rooms, or self-assessment. And why this is important is what you can do is you can actually just include those studies. So here, for instance, I included only the studies that used blended learning, and you get this value here, so 0.84 with a confidence interval, and then you know what these 3 studies together, how they then perform, as opposed to if you look at the other studies which did not have blended learning. So these had CIA alone. And then you come up with these confidence intervals well, effect size and confidence intervals, which help you to then come up with these sub-analyses for a forest plot looking like this. And what this helped us to do is actually identify the studies and why these studies performed better with higher effect sizes. You can see here the study by Chutkar, which had a 1.09 effect size. And what we could see here is that they used blended learning, unrestricted access with deliberate practice. And just a screenshot on your behalf, if you'd quickly like that, is how to calculate the effect size. It's E size unpaired, and then you use the second variable equals the other variable that it's compared with, and that will give you an effect size. And that's how you can calculate it for each of these studies. Yeah, so I think that's in a nutshell what we found in our study. I mean, in conclusion to the systematic review is that computer-assisted instruction was not better than face-to-face teaching, and the students benefited from it. However, when it was a blended learning approach and combined to face-to-face lectures, and where they used it also with integration with other multimedia elements and interactive quizzes, as I showed in this last sub-analysis. And importantly, also when they had opportunities for self-assessment with feedback. In summary to this talk, just the choice between the mean difference and standardized mean difference depends really on the context of the study and the nature of the data being compared. So mean difference is for absolute difference between groups with the mean values of the two groups, and the standardized mean difference is the difference between mean values of two groups expressed in the standard deviation units. So basically, you using the standard deviation to create a new unit so that you can actually compare apples with apples. So you use the MD or mean difference when the measurement units are the same across studies. So to give you a clear, directly interpretable result. What's nice about the MD is it actually gives you to what extent did, let's say, blood pressure treatment affect the blood pressure. SMD doesn't give you that because it doesn't tell us, but the mean difference can tell you. When you compare, if you put a patient on drug X and you compare across all the studies, it brings down the blood pressure by a set mean difference. And it gives you that actual value, as opposed to the standardized mean difference doesn't give you that actual value. However, what it does give you is this value, which is similar to an effect size. So you can actually see if it's clinically relevant or not. So slight difference interpretation there. And again, so mean difference used in the studies, for instance, blood pressure. That's a nice one because the unit in which it's measured is all the same, millimeters mercury, as opposed to standardized mean difference, like in this study where tests were all different. Or, I mean, we're looking at ECG competence, but the way that it was assessed was all different. Here, for instance, another example in cognitive performance. There are multiple ways in doing that. And when you'd like to compare all of those and get a unit which it's all the same, that's the way for it. And then just what about the fixed effects model and the random effects model? I've shown you this slide before, but the fixed effects really assumes that there's a true effect size, the same in all the studies. It represents a common effect size, and appropriate when the studies are very similar in terms of participants, interventions, and outcomes. But you should use the random effects model if there's a lot of variability. So it's appropriate when studies are diverse and expected to have different underlying effect sizes. Yeah, so that's in a nutshell my experience with using standardized mean difference and random effects model in making sense of these studies. And yeah, happy to take your questions.
Thanks so much, Charle. Really, really fascinating, and that you navigated. I'm presuming you navigated this sort of for the first time with this paper of yours, which is really innovative. What you've done here, and hopefully we can all learn and follow in your footsteps. So yeah,
Thanks,
we've got a couple of questions in the chat. I'm not sure if they've been answered now, but let me just read some of them out to you. We've got from Annalisa, you mentioned determining the mean difference from the SAFE rating instrument. How do you determine the mean difference from different instruments? Is this when you conducted a qualitative analysis? How do you interpret those results in layman's terms? And then she's got it standardized difference here. I'm not
Sorry,
sure.
where's this question? Sorry, I just want to quickly read that again. Oh, there we go.
Chat, yeah, can you see
Lisa,
it?
so you mentioned determining the mean difference from the SAFE rating instrument. How do you determine the mean difference from different instruments? So that's the whole point. So if you have different instruments and they don't use the same unit in which it's measured, then you can't use the mean difference. So that's when you use the standardized mean difference. That's exactly when it's used. So yeah, okay, got it. Standardized difference. So then she answered that.
Sorry, yeah,
yeah.
Got it from the presentation. I'm not sure if the other, how does one determine those cutoff values? Might have been something you said while you were saying it too.
Oh, the cutoff values. Yeah, so that's actually quite, I mean, and it's something I enjoy in other forms of research as well, is when results are often presented in a table, people will put that table 1 up, and then they just run on the right column and they look at the p-values and they look at where are the p-values less than 0.001, and then they start looking for where the differences are. And all that tells us is that there's a statistical difference between the two values, but it often doesn't tell you what the clinical relevance of that is. And I'll give you an example. So say, for instance, in heart failure management, there's a new drug that comes onto the market, and we now include 25,000 patients. By having a large sample size, statistical significance is often reached. But by giving the drug, the patient who actually got the real drug and not the placebo can walk 5 meters further on a 6-minute walk test than the other patient, or the groups of patients who didn't receive it. Then the p-value might look like there's statistical significance, but the actual effect size might not be relevant. So is 5 meters really significant? Doesn't depend on the p-value. And I really think that needs to be stressed. And that's what's very nice about using the standardized mean difference versus the mean difference, because the mean difference tells you what the actual value is. It's like blood pressure measurements. Everything in the same unit, millimeters mercury. And we know that giving drug X, pool all of that together, will bring down your blood pressure across 40 studies by, let's say, 8 millimeters mercury. But now you need to ask yourself the question, but is that clinically clinically relevant? Is 8 millimeters of mercury actually relevant? And that's where effect size comes in. And it's not a p-value. And I think that's where the standardized mean difference has a second value. It's not only it gives us the same unit, but what it also allows is it gives you some kind of measure like an effect size, the Cohen's d, where 0.2 is small, 0.5 is moderate, 0.8 or large is large, and even bigger than that, sometimes very large. And that's the second value for me, of looking at that result at the SMD. But crucial to understand that SMD result is not the actual change in value. It is interpreted like an effect size. Is the effect small, moderate, or large? And then Amir asked a very good question here. I'm wondering if possible to conduct subgroup analysis according to the type of intervention. Absolutely, Amir. I also did that in this study. I just showed different examples. But so if you go back, perhaps I should just share my screen again. That's a very good question, and that's actually something I would encourage people to do when you conduct your where's the when you do your analyses. Is what we did is you get your, let's say you have your 15 odd studies here, and then you say, okay, I would like to include only the studies that had randomized control trials. Then you end up with something looking like this. And then the patients which had an observational, let's say they were just observational in a prospective observational trial. So just another example. So, I mean, you could create whatever sub-analyses you like, and then look at these standardized mean differences with a confidence interval for that group in particular. How to interpret that is interesting, because how do you now compare these two? And this is important, because that's where, if the intervals, let's take this one, in the studies which used images versus the studies that didn't, there's a statistical difference here because the confidence intervals don't cross. And that's how you would interpret this. So you can do whatever, I mean, not a statistician, but you could subcategorize the studies according to their characteristics and look at it that way. However, one must also be careful, because I mean that's only this is almost like a univariable analysis, right? I mean, you're not taking in consideration other things. Yeah, if you looked at only these studies compared to only the studies which had blended learning versus studies which had computerized instruction alone, you can see that there's a clear difference. But obviously, there could be other things also accounting for it. I mean, that is the limitation, of course, when running a sub-analysis like this.
Thanks, Charle, and yeah, thanks, Annalisa and Amir, for the questions. I don't know if there are any other questions or comments. Anybody who's done a similar thing or used this kind of method?
Yeah, I'd actually like to hear from the audience if someone else is using this or can see use for it.
Maybe while our audience respond, you can even just give a thumbs up or some. Charle, I'm wondering if you've used this in another context. Have you used this for any other studies that you've done?
I've only used it for this particular study because the other studies had all measures which were the same.
Okay.
Yeah, and I think I ran into trouble, and that's why I went to Mark Engel and I said, please help, because I don't know what to make of this. It's a fruit salad, and how does one, compare apples with pears
I like your analogy.
and
Yeah.
call them all fruit.
Yeah. Yeah.
Yeah.
See, we have some typers. Anyone in our audience? Yeah.
Yeah, great.
Oh, well, thanks, Charle. Really, really fascinating and interesting methodology. And I'm sure and hope people have really learned a lot. I see we've got from Annalisa, she's saying she definitely can. Would one use this to analyze, for example, the difference in detecting HPV using PCR and pap smear? Just a systematic review that she has in mind. Yeah.
Yeah, as long as you're going to have, so what one needs for this, and that's also important, you need a mean result, and you need a standard deviation. You could see that from my talk. Whenever there wasn't a standard deviation, for instance, it fell out. So what you're going to need is you're going to need those two things to run this. But then it just depends on whether the actual, like it sounds like from this, is detecting HPV, you're going to have a mean result and you're going to have a standard deviation. But the way that this was done was different. I think this is exactly where you would use SMD. And I think, Annalisa, that's what you would use. And then she also asks, what if you have the median with IQR? There is a way of converting a median with intervals, acute interquartile range to a mean with standard deviation. I don't have the reference off heart. There is a calculation also for that. I can share that with Sarah. There's a nice publication how you can do that. But then you, in your methods, have to say that whenever it was not available, you had to correct it for it. But you can convert back to, I had to do it for, I think, 2 studies where also the authors didn't reply to me. So that is definitely possible. I'll share that article with you, Sarah. And then the other one was simple or stupid question. I just wanted to know, in your opinion, how might the choice of measuring instruments impact the interpretation of the SMD in a meta-analysis, and what considerations can researchers keep in mind when synthesizing the results from the studies using diverse instrumentation? Now, that's a difficult question. I think you need to understand what it is that you get from the standardized mean difference. It's not the actual difference. So the mean difference gives you what is the actual difference, whereas the standardized mean difference just gives you that, like an effect size. Is it small, moderate, large? That's what you basically see from it. That's my simplified clinician way of looking at medical research. Is that's what you look at the SMD. Yeah.
Thanks, Charle, and yeah, thanks everyone for the great questions. And yeah, hopefully we'll see people now thinking about or using this method going forward in systematic reviews. So yeah, really thank you again, Charle. Really
Yeah.
appreciate you giving up your time.